Welcome to the Ask the Expert Women series. I'm Lisa Chase, your host, and today I have one of my dear friends and colleague that I worked with many years ago, and we've stayed very close, Durley Munoz. Welcome today.
Thank you, Lisa. It's so great to be here with you and see where you have been done. I love this idea of the wellness series. And again, we go back, I don't even know how many years now,
So many.
but
So
no, doesn't
many.
matter which path we go, we always come back together. So it's great to do this with you.
It is. It's so great. And you have such a great background. I've loved watching you grow and add all these tools, to your toolkit in helping your patients. So you're currently at the University of Florida Health, correct?
Correct, in
In
Gainesville.
Gainesville, yep. And then you received your board certification in oncology for physical therapy specifically. And that is really going to help us dive in more today to talk about, rehabilitation with cancer patients. But originally from Bogota, Colombia.
Right.
And you've done also a lot of advanced training in manual therapy through the University of St. Augustine, aquatic therapy, cranial facial work, dry needling, lymphedema. I know that you have a special interest in, research for breast-related lymphedema. And so we're going to be talking a little bit more about that. So I'm interested in your insight because I don't know that there's tons of physical therapists that are doing lymphedema work, but it is very important work that really can help our women. And then you have a great podcast that you've been doing for what, almost 2 years?
2 years. Yeah, yeah.
Wow,
Yeah.
calling, yeah, it's called Taking Care or Taking Charge of My Cancer. So we'll definitely put a link in for you and for our audience so they can find you. But I'm curious, what because you have such an eclectic background, what made you get interested in cancer rehabilitation?
So actually, that was not on my plan at all.
Okay.
I've been an orthopedic physical therapy for many years, and that's how we met. And a very strong manual therapist, and kind of specialized in a lot of like spine and temporomandibular disorders. And when I was working here at UF, and I've been here for a while, they were look. I always kind of wanna move into a lead kind of role, and but I was not interested in to take like a management position or anything like that.
Hmm.
So that was an opportunity for we were having an oncology program, kind of developing an oncology program, and one of the therapists was planning to. They didn't really have a full-time person. There was somebody part-time, and the other person was kind of part of faculty here at UF with the PT school. And so she was not full time on that. So they approached me and said, you kind of have some interest in leading a program. What about this? And I'm like, wait a minute. I have absolutely no idea about oncology, but let
Yeah.
me go shadow my colleague Shannon and then see what is all this about. So
Yeah.
I came and shadowed her, and within 2 days, I'm totally fall in love with the patients. So initially, I thought, I don't know if it's going to be for me because my first thought was, ooh, this is oncology. I'm such a high energy pusher. You're going to work hard. And I was like, I don't know if I'm going to be able to make these patients do this because in my mind, I thought an oncological patient was somebody who was more fragile. Uh,
Mm.
they were going to be really, depression. That was going to be a very sad situation. And I'm a crybaby. So I'm like, I'm gonna be crying my eyes every day here. I don't know if
Yeah.
I wanna be on that situation. And to my surprise, when I started shadowing Shannon, I was like, oh my God, this is the more amazing kind of like they're so grateful. And I was able to apply all my manual therapy skills in this population. So I was like, actually, I think I like that. I have no idea what I'm gonna do, but I'm gonna be doing some continuing education and some learning and let's give it a shot. And here I am 17 years later, and we went from like one and a half therapists to now it's seven of us. And then we start to create this beautiful program we have now. And then
Ah,
with that then came along, become a manual therapy certified. I'm sorry, lymphedema therapy certified, and then We have the APTA finally put out on a specialty in oncology. That was
Yeah.
back in 2019. So we did it with one of my colleagues in 2020, right around COVID time. And again, so here I am. So rolling and learning. And again, I don't regret it one bit. I think it's just really amazing.
Well, I always, am amazed at just you push yourself all the time, right? Every time I talk to you, it's something new you're doing. You're like, okay, one time it's aquatics, and next time, it was the you started doing lymphedema, I think before you did cancer. So I love, how you constantly are pushing yourself to learn and grow and, and really be able to, to help so many more patients. So well, let's kind of start with your perspective of how does physical therapy fit into women's cancer journey, kind of from diagnosis to recovery?
So it's a huge role, and it is a role that is under recognized.
Yeah.
So many times, even, as well, like the clinical coordinator for this clinic for education for students all over the place. And a lot of the students coming here, like, I have no idea. Like, I'm going to this oncology internship and I have zero idea. Even in PT school, we learn like what, one lecture maybe
Yeah, maybe.
oncology and one lecture that actually I give to here at UF in lymphedema. So it's not really that much education, unfortunately. But from the moment of diagnosis, PT can help prepare for body for surgery, chemotherapy, radiation by optimize strength, mobility, and breathing mechanics. So early education can also empower women to understand that to expect or how to minimize all these side effects, right? So
Yeah.
during treatment, physical therapists can help manage pain, neuropathy, changes in posture, movement patterns. Sorry, we also address swelling and lymphedema that can start early. So preventing or really having an early surveillance is super crucial. So one
Mm.
of the things that again treatment is really all depends what kind of treatment. So in breast cancer in particular, treatment start from the time of diagnosis, right? So
Hmm.
usually we see the majority of our patients right within 2 weeks after diagnosis.
Oh,
So
okay.
we get to do like a base. So we have a really great prospective lymphedema breast cancer related surveillance program. So we start seeing these patients pre-op so we can do a baseline because how do I know that you develop lymphedema if I don't know what your arms look like prior to surgery, right?
Right.
We establish a baseline evaluation so we can do that. And then in that moment, the whole education starts. So we then can guide patients into this is what can happen, but are you going to have, because it's something called neoadjuvant chemotherapy, which you can have chemotherapy before surgery, depending on what type of tumor you have and stage and so forth. So if you're going on the path of surgery, we see you prior and then we see you 2 weeks after surgery and then we follow up to 5 years. And I'll go more in detail about that. But if you're going on the path of chemotherapy, then our treatment is going to be, oh, wow, we need to really focus here and mitigate a lot of these side effects. So, what are the side effects of chemotherapy? The main one that we see a lot is chemo-induced neuropathy, which
Mm.
for the audience means tingly sensation on the hands and feet. And what is that guy is going to drop you to into increase your fall risk. So it
Yes.
really add a lot of issues with it, like let's look and see what is your sensation look like. Let's look what your joint mobility looks like on your ankle and your legs, and what is it your strength and your balance, and let's start to see if you're doing great. Let's continue enhancing exercises towards keeping preserving that versus let's just be proactive versus reactive, right? And
Yeah.
then it's another huge thing, which is cancer-related fatigue. That's
Mhm.
really something that we see quite often when patients go through chemotherapy.
Mm.
So exercise is amazing for this. Actually, that's what the research shows. The research shows that the best way to fight cancer-related fatigue is 150 minutes of aerobic exercise a week, up
Mm.
to 3 times strength training.
Okay.
We kind of really become really proactive in guiding through that. So if it's the situation where we go, okay, now I'm seeing you post surgery. So again, it's a lot of things that happen after surgery, right? So the main thing is mobility of the shoulders. So we start looking into all this mobility How can we really rebuild that ability to go back into your normal life as easy as fastening your bra or washing your hair or doing the day-to-day activities that you do? And how can we get you to that optimal function before you even start radiation, if that's the case? And if you end up in radiation, a different ball game because other things are going to be happening with that. So really, the treatment goes based on which direction you go. And then after all this is done, then we have left over with all these side effects that all these cancer treatments left you with that
Yeah.
we can control, which we'll talk more in detail.
Yeah. Okay. Well, what do you find? So we've talked about fatigue, weakness, neuropathy. What are some other common physical challenges women face during or after cancer treatment, especially with, I think, breast cancer?
I think besides the typical that we see, one of the things that I see happening a lot is pelvic health issues. So,
Okay.
why is that? So we know that the majority of breast cancer can be hormone positive type of breast cancer. So that means that estrogen or progesterone is positive on their tumor markers. So with that, it's going to take this woman is for them to get prescribed what we call endocrine therapy or hormone blockers. So they're going to take medications who are going to block estrogen and progesterone depending where they are. So what
Ah,
happens if you block your estrogen, right? So it's gonna go down, right? So we
mhm.
know that usually, we know menopause, right? And it's a huge movement on menopause right now. So
Yes.
we know that, close to 50, we go down into menopause. And what that means is estrogen, progesterone, testosterone, everything goes down. Imagine that you are 50 years old and you're going to face menopause. And instead of your body take you there, now you're taking a pill that is going to drop you down.
Mhm.
So all these side effects of lower estrogen is going to put your life in risk because then what happened with lack of estrogen, right? We're going to have cardiovascular issues,
Yes.
Alzheimer's, osteoporosis, and all
Yeah.
this what is now called genitourinary syndrome, which is actually atrophy of the vaginal wall. And we're
Yeah.
looking into multiple UTIs, which will happen if you have a UTI. You have mental changes. Most of the hospitalizations with mental changes is because UTIs. And then if you're in the hospital, you can fall and you become weak. And if you already have some issues with osteopenia or weakness in your bone, that you can have a fracture. And then hip fractures is terrible. So one thing after the other. So sometimes people don't realize that, right? Like, you go into
Yeah.
this path of, I have a breast cancer diagnosis, is super overwhelming. The first thing you're thinking is, I want to be alive, right? You hear the word cancer, I'm going to die.
Yeah.
I'm going to leave my kids or significant others or whoever is around them. And then you just worry about, let's take care of this cancer. Let's get this out of me. Let me do any treatment I need to just be alive here. And then you start to realize when treatment goes by, it's like, oh, wait, why do I feel like I have night sweats? I cannot sleep. I'm gaining this weight with like from nowhere. And I'm doing the same things I used to do before. And now my sexual life just went down to the drain because it's not just my libido, but as well it's super painful. And I don't enjoy it anymore. I have nothing to do with that because again, now you have a physical things that is happening, and at the same time, again, your estrogen is down.
Yeah.
So it is really a lot of things that we need to start to take in consideration. So now we try to do more proactive and start asking these symptoms at the pre-op visit. We ask the patients, like, do you have any issues with incontinence, constipation, intravaginal pain, like, or like with intercourse as well, or you having any issues when you go to the gynecologist for you to have a pelvic examination. So we know that for sure, if this happening already prior to any treatment, then we start to recommend them to go into pelvic health physical therapy, and they can really help you to start addressing these symptoms.
Yeah, I think those are really great points that, it's a trickle down effect for
Yes.
sure. One thing causes many more things and then,
Yeah.
you get overwhelmed and yeah, so I think those are really great points. So you talked about exercise for managing fatigue, weakness, mobility issues, after surgery or radiation. You know, let's explore a little bit more about movement and therapy and how it kind of can safely support women's energy, their strength as they're recovering. Because, obviously when you're fatigued, you don't feel like exercising, but, you
Yeah,
need to exercise
yeah.
and move in order to help. So how do you counteract that?
Yes. So all that you just mentioned, fatigue, weakness, mobility limitation, and extremely common and after breast cancer, but the movement is one of the most powerful evidence-based tools that we have for recovery. We know that. So again, if we start movement from the beginning, right? So that's why we do this education. It is okay for you to move after surgery. Again, depending on the surgeon, depending on what kind of breast reconstruction you're gonna have. Sometimes plastic surgery can limit your mobility, right? And you just have to follow that. But after that is over, the more you can move prior to it, and the more we educate the woman that is going through this into it's okay to move. You're not going to hurt anything if you move because what's going to happen, right? You have a mastectomy. Your body is going to go into this kind of protection mode, right? So we're going to
Mhm.
protect. We're going to just, everything is going to get tight. A lot of them just sleep incline in the first few weeks because going flat hurts.
Yeah.
So then if we start to teach them and educate them into it's okay to move and we give them certain exercises that they are okay to do right after surgery and we usually see them 2 weeks after. So we start really early on in getting them feeling comfortable, right? Because it's
Mm.
scary to move something that hurts. It's scary to move something you have a drain and you have all these stitches and you just don't want to hurt yourself. And it's not just the patient, but it's the family around, right? So it's like,
Sure.
oh no, don't do anything. You just sit in bed. I'm gonna bring everything to you. Don't move. Don't do anything.
Yeah.
And that's the worst we can do because we know
Yeah.
motion is lotion, right? So the sooner
Yeah.
you start moving, the better you're gonna feel.
Yeah.
That your energy is going to improve. With that, your strength is going to improve. So the whole point is let's get them moving to almost base back to normal before
Mm.
even radiation treatments start. Because what happens when radiation start? Then
Yeah.
you're
Even.
now facing inflammatory issues. Then you face a lot of issues with fibrosis radiation or radiation fibrosis,
Yes.
where the tissue is going to become really tight. So that's super important. So as the strength return and we get things moving, then you can start increasing that mobility and then get back into your normal activities, base activities like I mentioned before, washing your hair, just getting dressed. If you have kids, be able to start to take care of your kids. In the beginning can be a lot of lifting restrictions, but after 4 weeks, you should be able to get back to normal. So that's kind of like the things that we try to really avoid to just really get into this posture set and start to really work into a lot of the mobility.
Yeah, and I think, just like we teach any patient, it doesn't have to be, an hour of exercise, right? It's just incorporating movement into your day.
Exactly.
Get up out of bed when you go to the bathroom, you can do some shoulder rolls and,
Exactly.
you can do some toe raises. So there's different things I think that you can incorporate throughout the day so it doesn't feel overwhelming and you start to
Okay.
integrate movement into your life.
Exactly. So it's things like even if you, because it's different, right? Again, movement and exercise and lifestyle goes back into what is it that you used to do before, right? So it's different to have somebody who is more sedentary than somebody who has been in sports and active and working out all the time. Their recovery is going to be completely different, right?
Yeah.
So for these patients who are tend to be more sedentary and they're really afraid of movement because that movement is not something that pop on their head all the time besides just doing the basic ADLs, then little small bouts of things, just little walks, like, 5-10 minutes walk a few times a day. As simple as get up, walk, and swing your arms instead of having your arms by your side. That
Yeah.
already helps,
Yeah.
right? So, like I said before, start going from being an inclined position to start lying flat. So fascia can start to really stretch, and then it's going to start to help with movement.
Great. So we've briefly touched on lymphedema And this is obviously something that, many breast cancer survivors worry about and experience. So can you just go into like, what is it? Why does it happen? And what can women do to prevent it, manage it when it happens?
Sure. So lymphedema is a chronic swelling that can develop in the arm, breast, chest wall, or hand after breast cancer treatment. Of course, can develop anywhere in the body depending what kind of trauma the body had, but we're talking specific for breast. And then this happens when part of the lymphatic system has been disrupted. Could be because surgery, most of the
Mm,
time that's the reason. Can be because the tumor itself, you can have cancer on your lymph nodes, and that's already creating a pressure, and then that is not making the lymphatic flow properly work, or can be radiation. So can be as well for a scar, right? So sometimes scarring on the area, because if the surgeon has to take some lymph nodes out, that can create some scarring that can decrease that flow that happen on the lymphatic system. So not
mhm,
everybody develop lymphedema, but the risk is a lifelong risk. So sometimes can
mm,
appear weeks after treatment, but usually when it's going to happen on the first 2 years for the most part.
mm,
Doesn't mean it's not going to happen later. So that's why our surveillance program is a 5-year program.
mm,
We see patients like every 3 months if they're high risk. And what that means by that is if they have more than 6 lymph nodes taken out, they become high risk because they have the research shows about 40% of possibility for these patients to develop lymphedema.
mm,
If 4 nodes or less, then we know it's going to be a lot less lymphedema in that case. So that's kind of the whole idea with that. So what we want to try to really focus on is if we start with prevention, right? So how can we treat lymphedema? Everything goes down to prevention. So if we really wait until, if we look at something and we keep, that's why it's called a surveillance program. We make sure that a symptoms doesn't develop. So what are the things we're looking for? So symptoms means all of a sudden you notice some tightness through your arm, or you really notice that your ring doesn't fit anymore, or you just look like the clothes doesn't fit any longer. You just feel like heaviness through the whole arm. So that's
mm,
one of the things. The other thing as well, when we looking into volume difference. So you look in physical therapy, we do circumferentials on the arms, and then we look into volume difference. We have the fortune to have a test called a bioimpedance device that look into a specific extracellular fluid difference between right and left arm. So that give us already a parameter because we locally saw you prior to surgery, so we know what your baseline looks like. So we have something to compare after to be able to diagnose. So I think the key is early detection, because if we can detect it early, definitely we can go back and get it back to normal. But
mm,
done, the more chronic gets, the worse gets, because one of the things that happen with the lymphatic fluid, that lymphatic fluid has protein on it, and then protein create that kind of fibrosis
mm,
tissue that after you become fibrotic, meaning very hard tissue, you really cannot go back into normal. So we try as long we can keep that tissue, like that tissue soft, and hopefully we can get back into it. How do we do that? So we do that with something called manual lymphatic drainage. We do that with compression garments. If in the beginning we have, it's called CDT, which is the congestive complete therapy, which means we're taking care of the skin. We do manual lymphatic drainage, where we kind of teach that lymphatics where you need to flow and what its direction needs to flow to. And then we do compression. And if it's really bad in the beginning, you may see some of those people wrapping, it's called bandages wrapping around, or we use other things called circuit kits to reduce that. And then hopefully we get you down to a point that can get you into a sleep during daytime. Perhaps an eye garment is other really great tools now called lymphedema pumps that can be a great tool to try to help with that. So the other thing as well that was a myth for years was people who develop lymphedema were like, well, you don't exercise. Don't do anything with that arm. Stop using it, which was totally wrong, because we want to use it, because the more we pump muscles, the more that lymph fluid is going to get pumped into that circulation.
mm,
So absolutely. So really, we don't hold patients back at all. As long as you have a good right compression, if you're a tennis player, I want you to go back and play tennis with the right compression. If you're a
mhm,
golfer, the same thing. If you're a swimmer, you're whatever you do, the more you do, the better off. they're going to be, because then this gets complicated with, if you don't move, what happens? You lose motion, you lose
Mhm.
strength, you start having these other orthopedic conditions like shoulder impingement, frozen shoulder.
True.
We start really looking into, again, all these other side effects or secondary effects from no movement. So that's kind of the main thing. So the good news is that early intervention is the best thing to do. And the other
Yeah.
great news is that has been so much research around lymphedema now that
Mm.
for years we know it's a chronic disease, and I don't think we can call it yet we can cure lymphedema, because
Mhm.
a lot of the bright doctors in the world, plastic surgeons, are working into that. Can we get to the point that we can come up with something where we can cure lymphedema? But
Mm.
has been a lot of great surgery types now that is happening to try to really manage that. And it's great. I actually, in one of, is Dr. Singhal out in Beth Israel at Harvard, and I have the pleasure to work with him here, and we did a lot of lymph node transplants. But now he is kind of like have an amazing lymphedema, clinic up in Harvard. And I just have him on my podcast not long ago, maybe like 2 months ago.
Mm.
They just kind of really discovering a lot of the newest thing on the anatomy of the lymphatic system, which is amazing.
Mm.
What we thought the anatomy looks like, and that's how I thought years ago when I became a lymphedema certified specialist, it's not like that anymore.
Oh.
It's like, oh my God. So has been a lot of excited research out of Australia, where we know that maybe the paths that we thought we were using that were not the right paths, we need to be using other paths. So it's a lot of really great excitement
Huh.
in really doing a lot of different things in a much better way. Like the one of the things that I'm super excited about is we do something called lymphovenous bypass. So what that means is at the time of the mastectomies or the surgeries, the surgeon, and our breast surgeon is great at that, take those lymph nodes out and then connect the veins that are close by to another lymphatics. So she makes
Mm.
bypasses, so she connect several channels. So what we try to do is increase flow into these other lymph nodes. So we already wrote a couple of papers on that. And then I mentioned that if you have 6 lymph nodes taken out, that give you a good 40% of chances to develop lymphedema, but or rates to develop lymphedema. But with the LV bypass, we dropped that to a 12%. And
Mm.
actually, Dr. Singhal up in Boston does the harvesting of the vein from the knee, and he dropped to 4%, which is amazing.
Wow.
Well, it is so many great things. And now that's a standard of care for us. So everybody who's going to have an axillary dissection, they get an LV bypass. So what she's doing now is during surgery, she's mapping your channels because, as I mentioned before, your lymphatic system is not the same like mine. So we thought that you have lymphatics this way, but perhaps what we're finding now is that most of the lymphatics is more medially, it's nothing on the outside. So why
Mm.
are we draining things on the outside when there's nothing there? So now she actually mapped the arm during surgery so we can see what is your path, so I can actually do a manual lymphatic drainage following that path. So it's
Mm.
exciting. But what they're doing in Australia, that's what we would love to do at one point here, is they actually do something called ICG, which is they just kind of inject anodyne green, which you can see like the whole like green lymphatics. And
Mm.
then you start doing manual lymphatic drainage as you see in that in the diagnostics, so you can actually see where the path goes and you can see how much pressure you can put so you can push that volume into that direction. So super
Wow.
excited. So it's like a live MLD with ICG. So that's kind of what we would love to get here. Dr. Singhal is doing that already at Boston, so hopefully we get around that here. But it is really exciting. It's really nice to see how individualized treatments are becoming now for cancer, not just lymphedema, but as well surgery, right? Used to be that they used to take, you have breast cancer, they took everything out. Breast,
Yeah.
all the lymph nodes. Now it's so many testing that it is that necessarily no.
Yeah.
If we can do just a lumpectomy where you can conserve your breast and that give you the same survivorship and the same kind of like, percentage of recurrence, why are we doing all these major surgery when there's no need for that? So
Yeah.
I think that the surgeons becoming as well smarter, and they start to realize that taking all wasn't the solution and it's not giving any better outcomes anyway. So why doing that? So they're more conscious about, let's just take one sentinel node or two, and then we just put less risk to lymphedema than doing what they used to do in the past.
Well, I think that's super informative. And I think, a really good point is that women just need to be more educated of their options, right? Because if you go to a surgeon and that's maybe their old school
Mhm.
versus somebody who is more familiar with some of the newer research, then, they go down a path that is like, there's no real return from that. So I think, doing, what we're doing now is, just talking about this so women can find information and be more educated, really helps to empower them to make the right decision, for
Exactly.
long-term health.
Exactly. And something that I hear more and more is like, when you get diagnosed, it's scary and you just want to move on and you don't want to get a second opinion because you feel that if you delay the process, you're
Sure,
going to get worse or your cancer is going to advance.
sure,
But
yeah,
it is not true. So usually many times when things show up, they just don't show up overnight. More likely something has been there already for a while.
yeah,
So women think like waiting a couple of weeks to just get a second opinion is not a bad idea at
yeah,
all. And
yeah.
then, and if you always come across for someone that you go and then they get upset because you're getting a second opinion, this is not the right doctor for you.
That's right.
So
That's
you gotta move on and find somebody who is willing to say, yeah, this is completely out of my scope, and try to really find people who knows what they're doing. We see that here all the time. You can have a general surgeon doing breast surgery versus a surgeon who had a fellowship in breast. That's all they do day in and day out. So they're gonna be more updated with the research. They're gonna be more updated with, no, let's don't take 20 notes when it's no need for that.
yes,
So
yes.
that
Really great,
definitely is, yeah.
great point. Well, look, we know that, beyond the physical side, cancer recovery can, really, take effect on our emotions, our mental health. So how does physical therapy, movement therapy, support that mind-body connection and overall wellness?
Well, they're very deeply connected, and cancer treatment impact both, right? So movement therapy plays a powerful role in supporting emotional well-being, right? Not just physical recovery. So we know that exercise helps to regulate stress hormones and increase endorphins, right? So they're our natural mood boosters. That's a reason why I work out at lunchtime every day, because I just get my system boost up, right? This is kind
Yeah.
of like wake me up, getting me like going, help with my fatigue. I don't need coffee. I just need to exercise to get that to that point. So many women report improvements in anxiety, depression, and feeling really, they have this feeling to being stuck in this body that they're recovering from surgery. And so definitely the fact that they're not able to do what they used to do, then you become really anxious. I mean, the fact that you have a cancer diagnosis already put you in an anxiety.
Sure.
And then the fact that you feel like, well, in the first 4 weeks, you can only move your arms to 90 degrees, and every time they're going to try to wash their hair, they can. All this, like, you just feel like you don't have power over yourself any longer. You have no control over everything you want to do every day. So so movement also rebuilds confidence. So really it's just that mind and body connection is amazing. We know that you can go and exercise, but if you're not really taking care of, are you doing any mind wellness, right? Like meditation, yoga, having counseling, I think is super important. One important tool that we have now, we have an occupational therapist that all he does is mental health. So it's amazing that he sees the patients as well before surgery and see like, where are you at on your, with all this, and give them a lot of tools in regarding, like I mentioned before, mindfulness. What else can you do? What can you have in control for what you can have in control now, and how you can put that in practice while you're going through these treatments. Sleep is huge, as we know that if
Mm.
you're not sleeping well, then you're going to be fatigued. You are not going to be able to tolerate as much. Your threshold for pain is higher. So that's super important as well. But if you start looking into, well, if you just have a breast cancer diagnosis, who is going to sleep, right? You're just thinking this in and out. So really supporting that. And as well, from a social standpoint, working with the therapists on joining a movement-based type of groups creates community. So you feel that you're understood and, and support, and that can dramatically help with that part of anxiety and depression. Cognitive function is huge. So we hear this chemo brain that sometimes I feel I have chemo brain and I have no even chemo cancer, right? Sometimes, how many times we have like, oh, wait, I was gonna tell you something. What was the word I was using? Because this is just part of, we're gonna blame it to our estrogen depletion. Uh, more than aging. And then, so definitely we know that exercise increase blood flow and neuroplasticity, and that really notice women after exercise, they kind of really notice more clarification, clarity, or they can focus better when they incorporate regular activity. And then again, you get movement give you a holistic foundation, right? Like really support physical recovery. And then that helps to reconnect with themselves. And like I mentioned before, just kind of rebuild that truly identity and control of yourself.
Yeah, and I mean, is so critical. And I think the other thing, you mentioned sleep. I think that kind of resetting and restoring our nervous system, right?
Yes.
That balance between our fight, flight, and our rest and digest. And there's a great technology that I use called Newcom, that is a neuroacoustic type of software that plays behind the music that you hear, and it activates the very, parts of the brain that allow you to get into that deep recovery and healing. And have done a lot of research on it with cancer patients, using that for, whether they say with cancer to do it for, a couple hours or at least an hour, a day, where you're just, closing the eyes and listening, to that, where it's activating that part of the brain that helps your body heal. So, yeah, I think it's just so critical to, to our healing, and like you said, to the pain, and, how overall you're feeling.
Yeah. And sometimes you can always talk to your physician as well about, there's so many supplements out there that you
Hmm.
can try to just, again, we kind of going into this kind of no Western medicine with a pill take care of the other thing, and a pill and more toxicity in your body versus how about if we start looking more holistic, right? How about if we try little things like acupuncture? Things like, so many like, herbs or teas or other supplements that are totally great for you and help you to get to that kind of deep sleep, how you mentioned it, that's what's going to allow you to heal. So again, always look into options for that and talk to your physicians to make sure that whatever you're taking is not going to be, counterproductive for with some of these supplements.
Yeah, definitely. So we've talked about lymphatic, drainage and therapy. Let's address the scar tissue, because that is, for so many, women after you've had surgery, the scar, and what that scar, can, inhibit or restrict. So, why is this so? It's really often overlooked. I don't think really physicians, they just want to kind of go in, do the surgery.
Yeah.
Yes, a little scar management, but there's so much more to that, to restoring function and comfort. So talk a little bit about, the impact of scar tissue.
Absolutely. So if we know we look at a scar tissue, we're thinking, well, that's an opening and just a scar down, and I'm gonna heal out of it, right? And I'll be fine. And I'm gonna move on and I'm gonna be doing fine. But it is something on the system called fascia. And it's like I always explain, it's like this sheet that's around all your bones, tissue, muscles, everywhere you are. So you have this long sheet on your body, and all of a sudden you get cut and you have to heal, and that scar is going to start to really become tight and tight as you heal, and then start pulling all these other fascia in multiple directions, and then you start looking into, well, I just have a lumpectomy, which that means just, just take the tumor and it's a small scar on your breast, but all that fascia start to pull into your shoulder, and then 3 4 months nobody did anything about it because it's a good case, let's pretend you didn't have any lymph nodes taken out. The surgeon didn't feel like you really need to go see physical therapy because your arm is moving great. You didn't have
Hmm.
any lymph nodes, so it's no risk for lymphedema. And just have a scar that is gonna heal. And you can put a little bit of like, coconut oil, Mederma, vitamin E, whatever you want to put on the scars, and it's gonna be just fine. And you move on your life. And then 3 4 months down the road, you start having this shoulder pain and shoulder impingement and you start feeling like, ooh, my breasts start being like hard and some swelling, what's going on? And that's when they come to us. And then what's happening is you start creating this that entrapment or lymphatic fluid that, you have all your lymphatic fluid like it, through your whole body circulates. And if you have something that is tight and doesn't allow to circulate, it's going to start to accumulate. So that's going to lead into some, in case of breast cancer, some breast swelling. Uh,
Mm.
and then all these fascia restrictions start to create again problems on your shoulder, your upper back. You may have some of this scar tissue. Let's pretend you have a scar now, you have lymph nodes sticking out, and you have a scar on your armpit. And that's going to be a bunch of nerve bundle underneath there. So you may start having some tingly sensation and start to really have these symptoms of like a nerve impingement happening down your arm. Is something else called axillary web syndrome that looks like some like guitar strings that is
Mm.
associated with that fascia, but as well is associated with the lymphatics. So that we have a lot of women that develop axillary web syndrome, and they come and they're like, I cannot move my arm because I feel all this pulling through here, and then I feel those cords all the way to my wrist. So all that is associated with the scar. So that's super important. And again, we know that we have to allow scars to heal. So it's not like we're going to be moving those scars at 2 weeks post surgery, right? Because
Sure.
we need to allow scar, but that doesn't mean that we can move the fascia around them until
Mhm.
they completely heal, and then we can go on the scar. So that's really, really important to take care of it. So again, the more you allow this to happen, and you're like, oh well, I just don't have time, or that get better. I just go and do a pec stretch or whatever I learned on YouTube and how to stretch my arm. But
Mhm.
until you really don't start to address it in that, working on that, what we call it in physical therapy, myofascial release or soft tissue mobilization, you are really not going to feel that. And sometimes you start then develop some neck pain that when you come to therapy because you have neck pain, and then
Yep.
boom, all this is associated with the scar that happens in that proximity. And sometimes even noise now in the proximity. We're looking at a mastectomy, right? And then we're looking at now it's in the middle of your chest, but then your whole fascia goes all the way through the other hip. And then you
Yeah.
start having hip pain. And
Yep.
that's because all that big old scar that happened on your chest a few years ago or a year or whatever. And now you're having all this impingement happening on the hip because all that fascia restrictions is then creating issues in other part of your body.
Yeah, I mean, I have seen this, where patients come in and they have neck pain and they have a mastectomy and they have scar there, but they're afraid to move it. They're afraid to touch it. They don't want to touch it. They don't, they've been told maybe by their doctor, oh, you're at risk for lymphedema, so don't do anything. Don't touch the scar.
Yeah,
And it just gets tighter and tighter and tighter. And really addressing that scar and restoring that mobility is what's going to help.
yeah, absolutely. Yep, absolutely.
Yeah. So what are some of the red flags that women should watch out for post surgery or treatment? And how can somebody like yourself, or an oncology specialist help?
Okay, so we're looking back from the beginning. So let's pretend you just have surgery and then you're just recovering from surgery, right? Within that first month. So the main thing you're gonna be looking is for any kind of infection, right? So is your breast or your scar area become red? Or you see it's something that is very common, more than what we wanted to see, something called seromas. It's like a fluid of like a fluid of a packet of fluid that accumulates. So when you have a mastectomy, they put some drains, and then the drain is just kind of carrying all that extra fluid out, right? And
Hmm.
then sometimes those drains get pulled out after a certain amount of drain doesn't happen anymore. And what you expected for the tissue to do is kind of like the drain is in the middle, and then for things to just heal, and then you're good. But sometimes things don't heal for whatever reason. Can be the surgical technique, can be that you overdid after surgery. It can be just, it's the way it is. It doesn't have to have an explanation. But then you develop this pocket of fluid right there in the middle, and that creates some swelling. And so you just kind of little, you touch it and you feel like it's like a little water bed, right? So those things that needs to be taking attention. So you need to reach out to your surgeon. Sometimes they do an ultrasound and they see, okay, we just allow the body just absorb, or we need to actually drain this out, because if we let it there, that's going to lead into an infection. But sometimes it's like most of the surgeons prefer not to do anything about it if it's not necessarily, because then we add the element of we're going to inject something to take something out, which is an infection, right?
Yeah.
Potential. So if we allow the body, but sometimes it's way too much fluid that they need to put another drain, or they need to drain it out. So I would say that's the main thing to look right after surgery. And then as after you recover, if you want to start looking, is, is that lymphedema, if you got lymph nodes removed? It's gonna be like I mentioned before. Do you feel any heaviness on your arm? Or you start feeling heaviness and all of a sudden you see redness, or many times patients who are more in risk for lymphedema, if you go work on the garden and you got a cut, or you get a mosquito bite because you were going on a hike, or you were just sitting on your backyard, and then you notice some redness and swelling, that's like an emergency room situation, because you can develop something called cellulitis that it can be very life threatening. So that's important. The other thing as well that we're looking into is mobility, right? Don't think that, well, my arm doesn't move, but it's because I just have surgery and it's gonna get there. Well, if it doesn't get there in a certain amount of time, then your joint is going to become stiff, and then you develop this thing called frozen shoulder, which is really
Yes.
painful and really hard to treat.
Yeah.
So don't think that it is normal to go what you go through. It is not normal, or can be normal within a time frame, but the best thing is for you to go and see an oncologist specialist, so they in physical therapy, so they can just really see, okay, guide you into, this is normal, this is something we can monitor. We don't have to worry yet to reach out to your doctor. Let's see, we can do some drainage and we can do different things on this seroma, we can see improving, or we use compression or something else. But if it doesn't improve within a week, then I want you in the surgeon office, or I'll be calling myself to the surgeon and say, hey, let's just do an ultrasound here just to make sure, right? So we can always try to manage that. But the best thing is for you to just look for help, instead of just thinking this is just normal and it's just gonna get better.
Yeah. Early intervention, right?
Exactly.
Especially
Exactly.
post-operatively,
Exactly.
infections, infection and lymphedema, I think in
Exactly.
what the scenario we're talking about are probably the two biggest, risk
Exactly.
factors.
Now, if we're going to move on out of that, you go into that kind of subacute stage, and now you're going to have radiation. Then this is another huge element on. So while radiation happen, it's going to create this tightness on the chest, so you can may have start having some shortness of breath, because you don't have the ability to really expand your chest, because this fibrosis is happening in there. So
Mhm.
that's super important as well. Or you can have issues as well, like swelling on the trunk post radiation. Radiation can create a lot of damage into the skin. So we're so lucky that we see everybody who goes through radiation. We get a referral for everybody goes through radiation. So we see them early on, again in the beginning, and we're able to give them education and look for these flags, and then we can start teaching them an exercise program to get things moving, right? And then to prevent or mitigate a lot of their side effects. If we look into chemotherapy, again, some patients is like, well, I'm expecting from chemo, yeah, to lose my hair in some of the chemo drugs, have this neuropathy, but it's to expect is, I'm going to get better. And all of a sudden you're falling, or you feel really unsteady. So again, look for physical therapy, because there's a lot of things we can do for neuropathy and help you with your balance and try to avoid those. It's a really good example of this, which is at the same time, it's a little bit sad, but we had a patient who she had chemotherapy and unfortunately was not sent to PT. She developed neuropathy, and then unfortunately they were like, well, that's part of the regimen. Just kind of like, yeah, we'll get better. And as she was walking, she had chemo prior to surgery, and as she was walking the morning of her surgery, she fell and broke her arm, the
Mm.
opposite. So here we go, right? So we have something that totally could be preventive.
Yeah.
Now she cannot have surgery on the arm. Now she's dealing with a fracture on the other side,
Mm.
and has to postpone surgery another month, where this now went from a stage 1 to stage 2, because this, so just create all these issues that is like, why are we being so reactive instead of being proactive.
Yeah, it's so
So
true. I had a patient pass away this year, actually, because exactly that, diagnosed and then had a fall and, ended up in the hospital. And, there were just all these extra complications that just didn't allow her to go through her cancer treatment. So, yeah.
yeah, so it's sad when you see that, but at the same time, kind of it's kind of like give me the power to go back to the medical oncologist and like, hey, you need to refer everybody, period. Let us
Mm-hmm.
see them, let us do an eval and let us triage them and let us give them the education. So they
Mm-hmm.
may doing great. And that's great, but you may don't feel well on your 4th week of chemo, or you may not feel the same way on the 12th week of chemo. And if you have any of these symptoms, please come back and see us, or you can start doing these exercises that are going to be helpful. The other thing that is really exciting, we used to think that, patients in chemo, oh, don't do anything. You're going to feel really sick. Don't move. Well, guess what? Now is a lot of studies looking into tumor environment when they see that when you exercise prior to chemo or radiation in a high interval, training, meaning like, you go 30 seconds up and then you go down
Mm-hmm.
30 seconds up or however time you want to do. So we're going to get
Mm-hmm.
that peak heart rate. And we're looking at 70% of the heart rate. So it's not really easy. But
Mm.
what that's happening is two things: is increasing oxygenation into the cancer cells. So it's kind of enhance the chemotherapy and the radiation. So it's more effective. And not only that, but it's creating so much. Like we just did a presentation for the medical oncologist last week, and we look into this paper looking into actually reducing the size of the tumor when you exercise versus when you're done. So which is
Mm.
like amazing.
Interesting.
And then
Wow.
how that can actually, if you have positive lymph nodes prior to surgery, can decrease the size where you don't have to have that many lymph nodes taken out, which is super great. That was another study. They talk a lot in ASCO last year. ASCO is like this big medical oncology conference that happen every year, like over 40,000 uh,
Mm.
people goes to that. And actually, it's exciting that a medical oncologist present this trial on exercise in colorectal cancer.
Wow.
They did like a 3-year follow-up, and they have an exercise group and an exercise and a group that was a control group, no exercise, same chemo, and they looked like the exercise group actually had a decrease of 47% of recurrence.
Wow.
They were actually
That's
looking into
incredible.
that.
Almost
Oh,
50%.
you got it. It's like, oh my God,
Wow.
it's actually exercise better than chemotherapy.
Wow.
So
Wow.
that
That's
was
cool.
that has been super excited on the PT oncology world, because
Yeah.
we present research, but when a medical oncology is doing it, definitely put us in a different level.
Sure.
So that has been great. So hopefully, so what we're doing now, we always been doing this for a while, where we have patients to come and we do a HIIT program, 45 minutes, work them out, aerobic and strength, and they go to their infusion. And
Yeah. Oh,
then
nice.
that has been really mitigating a lot of their symptoms, like decreased
Wow.
related fatigue, less nausea, they react better with chemo, less
Oh,
neuropathy. So it has been really excited. So, and again,
wow.
them, we don't have to see them weekly, but we get them to get to the program, make sure they got it right, and then it's like they continue doing that on their own, and then maybe see them halfway through chemo, make sure they're okay. We can modify exercise. It's gonna be chemo weeks that are gonna be harder, so they may cannot doing as a high level, but then you can go lower, and then you can start that exercise program on somebody who is sedentary as well, just going to a little lower level.
Sure.
So that has been very excited.
Wow. Yeah, that's really, I didn't know that. So that's really cool. Well, we're almost out of time. We've just been talking
Yes,
away and
yes.
you've sharing so much great information. To wrap up, is there anything else that you want our women to know? And, you know,
I
any,
think I think that my major advice is, again, you get faced with this major diagnosis. Know that you don't have to do this yourself. You
yeah,
have a lot of people surround you. You have, don't be like, no, I can do this by myself. I'm going to take on into this because I don't want to bother anybody around you. So, no, just take advantage of people around you. Let them help you going through this process, from like physical, mental health. Don't be afraid to be your own advocacy. don't believe everything your doctor tell you. you
Yeah.
know, going to good research though, don't Google it, but you go to the right American Cancer Society or the right ways to go and look into what is the latest research for this. How are people managing this now? Because
Yeah.
you know we talked about this before. You can just go into somebody who is more old school and they're not on top of research, and you can really regret it afterward. So you
Yeah.
always go look and see and ask them, know how many surgeries do you do a day? What is your
Yeah.
background? Did you do a
Yeah.
fellowship? What are your thoughts about how do you keep lymphedema from happening? What does your
Yep.
surgical techniques look like? I mean,
Yeah.
you have all the rights to ask for that and
Yeah.
get second opinions, you know?
Yeah.
It's like, and then just don't let, like, you gotta be in the game, you know? If you get exposed to any, I always tell patients, you know, when they're in these endocrine therapy and hormone blockers and they're miserable, it's like, do you really wanna do this the rest of your life? Or you
Yeah.
put on the balance what is quality of life versus risk for recurrence, right? Because I always say, you don't know how much longer you have in this life. I can walk outside today and get hit by a bus and die.
Yeah.
And then you're worried so much about this recurrence, but you're miserable. You can't sleep. You have, you know, you're a 90-year-old in a 40-year-old body. It's like there's no, you know, so it's just a lot of things that you're gonna have to take in consideration. And the most important thing is quality of life. So my advice is just kind of like take charge of your cancer, take charge
Yeah.
of your, you know, treatments. Don't feel afraid to write a bunch of questions and say to your doctor, you don't leave this room until you answer all this, right? Sorry, you're not going to have 5 minutes with me, so just be prepared for that. And then
Yeah.
just tell them. And then again, physical therapy is amazing. That really not that many people knows that oncology physical therapy even exists, and it is so powerful and can really make a difference on their treatment journey.
Well, this has been fantastic. I've learned so much and I just love, hearing about all of this and knowing that we're going to try to get this information out to more women and I think women can be more empowered with knowledge and you just shared some great knowledge. So thank you.
Thank you, Lisa. Thank you for having me.
Awesome. All right. Well, until next time, keep moving.
All right, perfect.